Good morning. My name is Dr. Stephen Katz. I'm a rheumatologist at the University of Alberta Hospital in Edmonton. It's my pleasure to come chat with you today about arthritis in lots of different forms, and hopefully more than anything else to get across the idea that arthritis is not just arthritis. I think we have this feeling out in the world and society that there isn't much that we can do for arthritis. It's something that we all just kind of have, and it is what it is. But hopefully I can show that there's more that we can do, and even more that's possible that we can do if we take it a little bit more than saying it's just arthritis. So what I'd like to talk about over the next little while is give an overview of, as I said, I'm a rheumatologist, what that is, because I think it's this very secret word that is poorly understood out in the world. Talk about what arthritis is and how common it is. Talk about how we identify who has arthritis in what form. How do we manage it? And then perhaps most importantly, I do want to leave lots of time at the end for open discussion that make sure that not talking about what I want to talk about, but you have me talk about what you really want to hear, and I can answer all your questions as best as I can. So what's rheumatology? Rheumatology is actually a relatively new field of medicine. It's been around officially, if you will, for about 70 years. And we're known for a whole bunch of things, but it's not kind of a perfect thing where we fit in a box. So we deal with lots of forms of arthritis, but we don't deal with all arthritis. A lot of our conditions are related to inflammation, so inflammatory diseases, but we don't see all diseases that are related to inflammation. And a lot of forms of arthritis and other diseases that we see are autoimmune in nature, meaning the immune system decides to attack our cells, but we do not see all autoimmune diseases. So I'm sure clearly that has cleared up what a rheumatologist is. We do have a long list of conditions that we see. So there's over 100 different forms of arthritis, and I use that term very broadly here, that rheumatologists typically will see. And it's important to know that these forms of arthritis affect more than just our joints. So really these are systemic conditions that can affect us head to toe. It's not just a joint problem, it is a body problem. Arthritis is common, so approximately 6 million Canadians and growing have some form of arthritis, which means about 650,000 Albertans have some form of arthritis. Put another way, 1 in 6 Canadians currently have arthritis, and that's expected to grow by an additional 3 million people over the next 10 years. But really, we have to keep in mind it's more than that number that's impacted by arthritis. So there's the direct impact, if you have arthritis, that you feel it, but there's all the people around us that are going to be impacted by someone having arthritis, be it your parents, your siblings, your children, your friends. You're all going to have some sort of impact because they have arthritis as well. So this is a very common condition. And it's not just a condition of we get it as we get older. It is actually not a disease exclusively of older people, but half of those with arthritis are under the age of 65. And in Edmonton, we actually have 4 pediatric rheumatologists who regularly are busy and seeing patients because anyone between the ages of 0 and 18 can have various forms of arthritis as well. Arthritis is generally more common in women. There are types of arthritis that we see more often in men, but on the whole, more common in women compared to men. And in the Indigenous population, data is a little bit old. Overall, about 1 in 5 will have arthritis, so more common than the general Canadian population. But there's actually a little bit more to the story here, and I'll share that in a little bit. So arthritis, trying to just frame it in different ways, affects 17% of the population. So if you look at a whole bunch of other conditions here, so I know Diabetes has been talked about at this conference in the past. So diabetes on average affects about 11% of the population. In fact, if you look at this list, arthritis is actually the most common symptomatic chronic disease in Canada. And yet, we don't hear about it as much as we probably should. It is a serious condition because it doesn't just cause joint pain. It impacts our mental health, right? When our body feels down, our mind is going to feel down, and it works the other way probably as well. It limits the activities that we do day to day. It limits our ability to work, to contribute to society. About 50% of folks, after about 10 years of having arthritis, are going to be limited in some sort of significant way. That's a big number. And not only those sorts of limits, but outside, we said arthritis is not just a joint problem. Arthritis can increase your risk for infection, for serious infection. It increases your risk for joint replacement surgery. It increases your risk for cardiovascular disease, for heart attacks, for stroke. Folks who have arthritis are at increased risk for these things. And arthritis, we may not think about it this way, actually causes early mortality, meaning that you can die earlier than you would have otherwise had you not had arthritis. And that's for the vast majority of forms of arthritis. At its core, arthritis is a condition that causes joint pain and or swelling, which comes from a joint. Arthritis can be acute, meaning that it can happen all of a sudden, be there for a few weeks, and then go away and never come back. Arthritis can be chronic, which means that it comes on and without help may never go away. Arthritis can be caused by lots of different things. It can be caused through, probably more complicated than this, but wear and tear. It can be caused by injury. It can be caused by autoimmune diseases. It can be subsequent to an infection. Lots of different reasons for arthritis. It can affect more than joints, and I've said that before. So it can affect your skin, eyes, heart, lungs, basically anything head to toe. And there's many different treatment options for arthritis. A lot of it depending on the type of arthritis that you have, but there are lots of options out there. And we'll get to that. I'm not planning on going through this, but this is just to give you a sense of all the different types of arthritis that I might see in a given day in a rheumatology practice. This is not a complete list, more just for effect. The two that I want to talk about today, because they're good exemplars of arthritis, is osteoarthritis and rheumatoid arthritis. I think sometimes those terms are used interchangeably, but very different sort of conditions. So osteoarthritis first. So osteoarthritis is the most common type of arthritis. It affects about 14% of the population, although it depends on how you count numbers, because sometimes the numbers are counted based on people who have osteoarthritis based on symptoms, sometimes based on x-ray findings, so forth. But that number is about right. Osteoarthritis is, in most cases, what we say when someone says they have arthritis. Usually what they mean, not all the time, but usually is that they mean they have osteoarthritis. Osteoarthritis is a type of arthritis that gets more common with age, but really anyone who's 30 and older probably has some degree of arthritis. It may not be symptomatic, may just be an x-ray finding, but it's probably there. Osteoarthritis is the type of arthritis that we call often wear and tear arthritis, although it's probably much more complicated than that, and probably there are some kind of immune-mediated features in the body, but that's beyond the scope of what we'll talk about today. Highlighted in the yellow here are the typical joints that are affected in osteoarthritis. So hip and knees, we hear a lot about that in the news, joint replacements there in particular, and that's often because of osteoarthritis. The base of the first toe, very commonplace. The base of the thumb can be a commonplace. And then kind of the distal tips of the fingers, Not so much that first joint there, but the other two joints you can see as well. Important, just keep that pattern in mind. We'll come back to that just so you can see the difference between this type and rheumatoid arthritis. Osteoarthritis does have a typical way that it presents. So it presents with joint pain, not surprisingly. That pain is usually worse with activity. It improves with rest. Often there's joint stiffness in the morning, so it takes some time to get moving, to kind of things not to gel as much. But usually that'll happen in 30 minutes at most, and usually a few minutes, 5-10 minutes for most people. The arthritis may lead to decreased range of motion, and that may be because the joint doesn't want to move as well, and maybe the pain itself. There may be signs of kind of bony enlargement in the joint, so often we'll see that in the fingers. That's things that joints are a little bit more knobby, if you will. Less common, but can happen, that there's swelling, actual fluid within the joint. But for osteoarthritis, we don't see that as often. So if it's going to happen, I would say more often in the knee than other joints. Osteoarthritis is diagnosed, we're able to identify it really through some simple sorts of tests. So first of all, it's talking to you. It's such a critical part of what we do. Listening to the story. As you saw on the previous slide, a lot of what happens with osteoarthritis is based on how it's affecting you day to day. We need to have that information. A physical exam is equally important, and in many cases, that may be all you need to make that diagnosis. Imaging can sometimes be helpful. In the majority of cases, that would be a simple X-ray of the joint that's affected. Sometimes an MRI may be called for as well. Blood tests really don't have much of a role in osteoarthritis. If there's some concerns of other things going on, if we're trying to rule other conditions out, but really not much of a role here. We'll come back to osteoarthritis. We'll talk about management shortly, but I want to move on to rheumatoid arthritis. So rheumatoid arthritis is our most common chronic inflammatory arthritis. It affects about 1% of the population, so as you can see, much less common than osteoarthritis, but much more common in women, about 3-to-1 ratio, and much more common in the indigenous population. So again, that 3-to-1 ratio. So about 3% of the indigenous population has rheumatoid arthritis. In Edmonton, we diagnose about 2 new cases every day each year of rheumatoid arthritis. That's a pretty big number. So you're talking about 700, 750 new cases every year, in addition to the thousands of folks with rheumatoid arthritis. We would estimate there's probably, Red Deer North, about 20,000 or so individuals who have rheumatoid arthritis. Just rheumatoid arthritis alone. Forget about any other of the chronic inflammatory types of arthritis. It really can affect any age. You can be 6 months old, you can be 95 years old and get rheumatoid arthritis for the very first time, but most commonly we'd see it between the ages of 40 and 60. Rheumatoid arthritis is an autoimmune disease, meaning the immune system, for some reason we don't understand why, decides to attack the joints. The best explanation of why, which really applies to any autoimmune disease, comes down to genetics and environment. So there's probably something in your genetics that predisposes you to getting arthritis, and there's probably something in the environment that triggers that to happen, but we're not entirely sure what that is genetically and what that is in the environment. It's still a little bit of a mystery. The one thing I would say, though, from an environmental point of view, is we know smoking can play a significant role to increase risk of getting rheumatoid arthritis. In fact, for someone who has, and again, we don't understand all the genetics, but a small component of genetics that we do understand, and they smoke, your risk of getting rheumatoid arthritis is 21 times higher than someone who doesn't have that genetic pattern and doesn't smoke. So for all the other reasons that we know to stop smoking, preventing reducing the risk of inflammatory arthritis, and actually better treatment, better outcomes, less pain. That's another great incentive. Here's the joints affected in rheumatoid arthritis. I'll just compare that again to osteoarthritis. You can see pretty much every joint can potentially be affected in rheumatoid arthritis. The ends of the fingers, much less common. The base of the thumbs, much less common. And while not on the picture, back also, lower back is pretty uncommon. But there's joints that aren't even listed here that you can get in rheumatoid arthritis. So left well enough alone, it really can impact head to toe, even just from a joint point of view. So we talked about osteoarthritis, the way that it can affect you. You can see with rheumatoid arthritis on the other side of the screen, the pattern's a little bit different. So rheumatoid arthritis actually feels better with a certain degree of activity compared to osteoarthritis, which is worse with activity. Rheumatoid arthritis is worse with rest. So you have swelling in the joint that starts to gel, and it just gets harder and harder to get things moving, which is why mornings are a harder time, where often you're stiff in the morning for at least an hour compared to the few minutes with osteoarthritis. And in rheumatoid arthritis, classic finding, the joints are swollen. In other words, there is fluid within the joints, which is what's causing the symptoms. Rheumatoid arthritis, and I've said this before, it's not just the joints that are affected, it is a systemic disease. And you can see all the different parts of the body and more that can be potentially impacted with rheumatoid arthritis. We don't see this as much as we used to, and part of that is because we treat earlier and our treatments are better. So this wider array of manifestations don't happen nearly as often, which is a great thing. Diagnosis, again, it's that same algorithm we talked about before. Getting a story from you is so critical. Physical exam is really important, and in the vast majority of cases, again, that may be enough information to make a diagnosis. Imaging here can be helpful, but certainly in many of our patients, it can be very normal. So x-rays, we actually hope are going to be normal. If there are changes due to rheumatoid arthritis, usually those changes happen later on, which means we haven't diagnosed as early as we'd like to prevent that damage from happening. Sometimes ultrasound of the joints can be helpful to look for subtle signs of swelling, which may be hard to see on physical exam. There are a number of blood tests that are associated with rheumatoid arthritis, and their role really is more prognostic in nature. In other words, if there are antibodies that are associated with rheumatoid arthritis, which can be helpful to say if someone may have worse disease than someone who's negative. Sometimes they can be helpful to see to help make a diagnosis, but certainly you can have perfect blood work in right across the board and still have very significant rheumatoid arthritis. This makes my point right here. So again, there is no blood test, no x-ray that will definitively diagnose rheumatoid arthritis. Talking to you, physical exam, really critical here. Rheumatoid factor, some of you may have heard of that. It is an antibody test which is associated with rheumatoid arthritis, as is a newer test been around for about 15 years now called an anti-CCP or cyclic citrullonated peptide antibody test. Again, both these tests really are more prognostic in nature, but often they can be used diagnostically as well. It would be unusual if you're CCP positive not to have rheumatoid arthritis, but both those tests can be negative, as I said before, and you can have normal tests. X-rays we talked about already, that we hope that they're actually normal. So that's kind of what arthritis is about. Can we make arthritis better though? What kind of intervention can we make? And the bottom line is yes, we can do better. And I kind of put those options to 3 different categories. So we can improve symptoms, we can improve function, and in some cases we actually can treat the underlying disease, the underlying arthritis. So osteoarthritis, we're still not great at treating the underlying disease. We can't take that away. But there are many options when it comes to symptoms and function. Rheumatoid arthritis, our focus often is actually treating the underlying disease, and by doing that, it also improves function and symptoms. And we'll talk about both those strategies. So symptoms, education. So just being here helps anyone here who may have arthritis, because knowledge is empowering. Knowing what to do and how to do it, when to do it, can make a difference in terms of how you do over time. Keeping active. Exercise is a good thing. I get asked all the time if I can do X, Y, or Z activity and if it's going to hurt your joints. And in general, being active is actually only a good thing for your joints. Keeping muscles strong around joints probably helps reduce pain. Weaker muscles probably adds to pain. You can certainly injure yourself, like anyone can injure yourself, but that risk isn't any higher than the next person. Activity is a good thing. You listen to your body. If it hurts, you slow down, you back off. You may sometimes need to adapt what those activities are, but keeping active, excellent part of this. And this includes exercise, stretching, maintaining strength, and sometimes it means working with someone to ensure that you're doing the best activities that you can to really optimize things. That's where a physiotherapist can be really helpful. Physiotherapy, to me, their role is education. Teach you things to do so you can go and do them on your own. Whole bunch of other things which I'm sure doesn't surprise anyone that they're on the list. So weight control, we know that higher weight, certainly for hips and knees, increases your risk of developing arthritis there, and by controlling weight more, that is going to ease kind of the support and work that they need to do. I don't have any specific recommendations with regards to diet, and we could talk about that a little bit more if you have any questions. But really the key thing here is well-balanced, healthy diet. It's good for your body, which means it is good for your joints. There's some suggestion that a Mediterranean style diet may have a little bit more benefit for arthritis, but it's not a strong recommendation. We talked about smoking earlier. It's worth repeating. Not smoking is good for your joints. Beyond that, bracing, splints, walking aids, no one necessarily wants these things, but they can help reduce pain, but also help allow for you to do things that you want to do, so it doesn't stop you from day-to-day activities, day-to-day function. So adaptation is really the key here, and that's where an occupational therapist that will work with you on optimizing function can be really helpful. So in the kitchen, looking at different sorts of tools and how you hold them, and what they look like, and things, so you don't have to grip as hard, and things like that can really make a big difference in terms of day-to-day life. Pain medications, if the other things aren't enough, acetaminophen or Tylenol, it's probably our weakest pain reliever. For a lot of folks it doesn't work, but it's also our safest pain reliever, so it's often worth a try. One of the things a lot of folks do with acetaminophen is they'll take it when the pain is there. If that works for you, that's fantastic. Acetaminophen probably works better when taken on a regular basis, kind of builds up in the system. Now we have to always be careful, we don't want to take too much, but you can safely take, most people, without knowing the rest of your health story, take a Tylenol Arthritis, so that just has 650 milligrams of acetaminophen in it, one tablet 4 times a day, and you do that for a week. If that helps, fantastic. You keep doing that, maybe 3 tablets, 2 tablets help, and if it doesn't, it's not going to help, you may as well stop. Anti-inflammatories, and there's a whole list of different ones, and these are over the counter. There's many more that you can get by prescription as well. There's topical ones as well, can be helpful. The topical ones, again, really safe. They work about 50% of the time, so if it works for you, that's fantastic, but if it doesn't, that's not surprising either. I think we do have to be cautious how often we use anti-inflammatories, because especially if used on a regular basis and used as we get older, the risk of potential problems in terms of upsetting stomach, high blood pressure, heart, kidney issues, those risks start to go up as well. There's a whole bunch of stronger pain medications It's really kind of outside the realm of what I want to talk about today, but for some people, certainly necessary, depending on how they're doing. Sometimes we can inject things into joints, which helps reduce pain and improve function. So a cortisone, a steroid injection is a relatively common thing that we do. There's products that have what's called hyaluronic acid in it, which can be helpful for some folks, although it can get a little bit pricey and doesn't necessarily work on the whole any better than a cortisone injection does. And of course, there's surgical options, especially for osteoarthritis. If we can't optimize pain, if we can't optimize function despite trying all these other things, that's really the time to talk to a surgeon about, in most cases, a joint replacement surgery. Often we're talking about hips and knees in that case. We talked a little bit about dietary before, but just wanted to bring up the concept of natural health products. There's a whole bunch of different options out there. The data is not great for them. We do have a natural health product database on our website, albertarheumatology.com, which does share the data for it, for kind of what we've found are more common products that are used. But as I said, the data is not great in terms of benefit, and some of them do have some risks, just like any medicine too. So just important to talk to your healthcare team if it is something that you're using. I have folks who swear by products, and in their case, that's great. I'm glad that it works, but we just don't have that data one way or the other to say definitively that we can recommend something. Rheumatoid arthritis, as opposed to osteoarthritis. So osteoarthritis really is what we've been talking about, is around treating symptoms, function, and there's a role for that for rheumatoid arthritis too, certainly. But you also we can treat the underlying disease. So a classic picture of rheumatoid arthritis hands, and you can see kind of the deformative changes that happen there. That really shouldn't happen in 2023. We can prevent this. Our goal of treatment with rheumatoid arthritis is to get to normal, as very close if we can, meaning no pain, no stiffness, no swelling, no limitations in activity, and prevent damage. We use a class of medications called disease-modifying anti-rheumatic drugs to treat rheumatoid arthritis. These are long-acting medications that take time to start to work, but really are there to treat the underlying disease, and by doing that helps with the symptoms. We have a whole host of different options, things like hydroxychloroquine or Plaquenil, sulfasalazine, methotrexate, leflunomide. Used to do gold shots actually for this as well. And I'm, again, happy to speak about any of those in more detail afterwards, but I didn't want to go too much of a medication talk today as well. But the point is, some of them are very mild, minimal side effects, really inexpensive, and then there's the other end of the spectrum where some of them can cost up to $20,000 a year, and those are more kind of biological DMARDs. Biologics are man-made antibodies which focus on particular parts of the immune system to modulate them, given these are autoimmune diseases, to try to get things back to normal. How are folks going to do if you have these conditions? So osteoarthritis, I think a lot of people think, is a disease that is just going to keep on getting worse. So once you have it, it's just going to be downhill. So honestly, for most people, that's not the case. It can happen, but that's not going to occur for most people. And there's actually folks where, while some of the wear and tear will happen, the pain actually will settle out, and that takes a long time to happen, 5 to 10 years, but it's not that it's just going to get worse and worse for most people. Rheumatoid arthritis, like I alluded to before, with treatment, folks can do very well and essentially have a normal, productive life and do all the things that they want to do. Without treatment, there's risk of disability within 10 years for 50% of folks, and actually risk of death 10 years earlier than expected as well. And again, a lot of that is heart disease and stroke. So in summary, we talked about the fact that arthritis is the most common symptomatic chronic disease. Arthritis comes in many different forms, and we focused on osteoarthritis and rheumatoid arthritis today. And I hope I've shared some strategies to show that arthritis isn't something we just have to live with, that there are things that we can do to make it feel better. In some cases, we're better at that than others, but without trying that we don't know, and we really should do our best to kind of optimize that to reduce pain, improve function, and ensure that we have the full life that we all deserve. Some resources here for you. So our website, albertarheumatology.com. We have a website called RheumDAS where you can get an objective disease activity score for how your arthritis is. We have over 150 videos on our YouTube page, and we're actually just launching a patient advisory council that certainly anyone is able to join, which really is receiving a regular newsletter and information about all things arthritis and rheumatology, and really being part of the team. So again, thank you so much for inviting me this morning. I've really appreciated this time, but at this point I'm very excited to answer any of your questions and continue the discussion about arthritis and share any information that you'd like to learn some more. Thank you.